Hello and welcome to the Past-Tesh video lecture series. I'm Justin Davies, I'm a cardiologist from Imperial College London. This is the first of 3 lectures which will take you through some of the important aspects of cardiology which may all come up in the MRCP Part 1 examination. The first lecture, we're focusing in on chest pain and looking at causes, diagnosis and treatment. The basis of this lecture is there is a question which I'll give you an opportunity to go through each of the multiple choice stems and then we'll explain the answers and look at some accompanying slides. So question 1. 45-year-old man presents with previously diagnosed type 2 diabetes to accident emergency department with severe central pain, nausea and sweating. He has several risk factors and the question goes on to ask what's the most appropriate intervention following this presentation. I'll give you one moment to think about that. If you elected for D, percutaneous coronary intervention, you'd be right. This man is presenting with clear symptoms of an acute myocardial infarction. He clearly has risk factors for coronary artery disease, including being a smoker, having diabetes, and hypertension. There is good evidence now to support primary PCI or primary percutaneous coronary intervention as the gold standard for treatment of this presentation. Whereas previously we may have elected for thrombolysis with either TPA type drugs such as alteplase or a streptokinase drug, now we know that primary PCI is the best option and will render patients with less symptomatic problems of heart failure in the long run and also has an improvement in survival from the acute episode. Of course, this stem here also tests your knowledge of prioritization because these are all drugs which you may use in and around management of an acute event. For instance, if someone presents with an acute coronary syndrome, you may administer low molecular weight heparin. And if someone presents in the cath lab and we need to go on to do intervention, we may well give a drug such as abciximab, which is a glycoprotein 2B3A receptor inhibitor. So clearly this question tests the management of this condition, but it also illustrates the importance of risk factors in being the cause of the underlying coronary artery disease. We know that blood pressure is a very, very important risk factor in determining arterial disease and both can predispose to stroke and congestive cardiac disease as well. In this slide here, on the left you see the relationship between blood pressure and stroke. The bottom left you can see a normal blood pressure of around 123 over 76 millimeters of mercury rising steadily to blood pressure 175 over 100. You can see the almost 16-fold increase in stroke with this rise of blood pressure, clearly showing how important good blood pressure control is as a cardiovascular risk factor preventing stroke. You can see a very similar relationship on the slide on the right-hand side to coronary heart disease, where as blood pressure rises, you have a marked increase in the risk of developing coronary heart disease. Blood pressure, of course, does not just predispose you to developing coronary artery disease, but it also predisposes to the development of renal disease. And in this slide here, you can see that in both Caucasians and the African American population, a very, very large study, as blood pressure rises, there's a marked increase in both the Caucasian and the Afro-Caribbean population of renal failure. Interesting to note that in every single blood pressure range, even starting from the very lowest range, around less than 117 millimeters of mercury, the Afro-Caribbean population has a far higher incidence of renal failure when compared to the Caucasian population. This, of course, may reflect other social or economic factors which we know also impact renal failure. Other well-known risk factors, which came up in the question, of course, you'll be familiar with your practice yourself, are the effects of cholesterol, both on coronary heart disease and cardiovascular death. Here, once again, we can see as cholesterol rises, here from 4 millimoles per litre going up to 6, the relative risk increases markedly from 0.5 to about 4. This is both for coronary heart disease and also for cardiovascular death. clearly indicating to us this is, again, a very, very important risk factor to control in terms of prevention of arterial disease, which can lead to coronary disease, stroke, and of course death. Diabetes, a growing epidemic, which certainly is now spreading from the developed world to the developing world, and certainly is a problem which will impact greatly on the burden of arterial disease we see in our practice in our lifetime. This is a marked cardiovascular risk factor for both coronary artery disease and for stroke as well. And certainly we should always pay very close attention to ensuring that we have the best diabetic control we can achieve. We can see that diabetes predisposes to a whole range of different diseases, ranging from stroke, coronary heart disease, congestive cardiac failure, and indeed all-cause mortality. And one can clearly see a marked difference in this study between the non-diabetic group across all these disease spectrums and the diabetic group. So once again, illustrating the importance of diabetes as a cardiovascular risk factor. Smoking. Smoking we've known about since the 40s as being important for lung cancer and more recently important for arterial disease. And certainly this is a major risk factor which we should try and control and limit at all costs, as it will predispose once again to the development of arterial disease. Now, we've spoken about these all in isolation, but almost certainly from a population level, from your patient's level, what's more important is how these all add up together to predispose to the development of disease. And here you can see in this Venn diagram, we have smoking giving a 1.6 increased chance of developing disease, elevated cholesterol a 4 times increased chance, and having blood pressure of more than 195, a 3 times increase. We can see when these are all added together, and if a patient indeed had all of these risk factors, it would summate to a 16-fold increase in developing arterial disease, which clearly is a markedly elevated risk and clearly puts a patient in a very, very different risk group than they would otherwise be if they didn't have these diseases. Now I'm going to move on to question 2. Question 2 is a 52-year-old man is undergoing an exercise tolerance test for coronary artery disease screening after suffering indigestion type pain whilst playing squash with a workmate. A very common presentation to clinic. He reaches stage 2 of the BRIS protocol when his blood pressure is 210 over 100, his heart rate is 170. Some ECG changes are noted. Which of the following is the strongest indicator for stopping the test? If you went for C, you're correct. A 2 millimeter ST depression in the lateral leads. Certainly exercise tolerance testing currently makes up the lion's share of non-invasive screening for coronary artery disease. There are several absolute factors which mean we should stop exercise testing, and we're going to cover those briefly. Looking through these alone here, a blood pressure of 210 is just about tolerable. Certainly anything over that we'd consider stopping, and indeed patients who develop a very hypertensive response during exercise tolerance testing is a predisposition for hypertension in the basal state. Heart rate, we wouldn't stop unless the heart rate became particularly elevated as a result of an arrhythmia. That may be ventricular tachycardia, atrial fibrillation, for example. Otherwise, we're of course looking to induce a tachycardia to really stress the heart. We try and avoid stopping at the patient's request unless that's absolutely necessary, and we try and encourage all our patients to push themselves as hard as possible, because clearly the validity of the test is at stake. If people stop when they've only achieved a very low workload, we know that the reliability of the test is low, whereas if they've achieved over 85% of their target heart rate, we know that the validity of the test is far greater. And lastly, ventricular ectopics. Well, ventricular ectopics, of course, can be seen on a resting ECG. They can also occur during exercise testing. There is some evidence from a single study which shows that subjects who have a lot of ventricular ectopics in recovery of exercise testing is related to coronary artery disease. But clearly, in this slide here, we can see that the clear differentiator, the one which points out that this patient is likely to require further investigation, is the fact that they develop ST depression during exercise. Now, one of the key points which candidates always fall down on is they try and assess, both in the exam and clinically, the ST segment immediately after the QRS complex. And this is incorrect, and the college will frequently test on this. When assessing an ST segment, it's important to look 80 milliseconds after the end of the QRS complex. The reason for this is if we induced a tachycardia in anyone, it takes time for the electrical activity to get back and above the isoelectric line. If we measure too early during a fast tachycardia, it'll make it look as though everyone has upsloping ST depression, which is clearly incorrect. In this slide here, you can see I've illustrated the J point, and to assess the ST segment, we need to measure 80 milliseconds or 2 small squares after that. We now move on to contraindications to exercise tolerance testing. So the first on the list here would clearly be subjects who are unable to exercise, and these may be patients who are wheelchair bound or subjects who feel they're unable to get a sufficiently high level to achieve a diagnostically useful exercise tolerance test. The next would be those in whom the ECG is ininterpretable, and these may include subjects with left ventricular hypertrophy and a strain pattern. And just remember, the strain pattern looks like T-wave inversion on your ECG. Of course, one of the diagnostic features we look for in induced ischemia. Subjects on digoxin, where they also have U waves, which again look like an ischemic ECG. Subjects in whom the QRS complex is abnormally widened, so these may include subjects with left bundle branch block, Wolff-Parkinson-White, or those who are paced. In these groups, it's very, very difficult to ascertain anything about the ST segment, and this can leave us to really relying basically on our diagnostic criteria falling down to symptoms alone and paying very little attention to the ECGs themselves. Next, we move on to the group of people in whom it's dangerous to exercise. These include subjects with acute coronary syndrome, those with severe hypertension, including blood pressure more than 210 millimeters of mercury, subjects with moderate or severe aortic stenosis or HOCM, subjects with left ventricular failure, and those with an inflammatory type condition such as myocarditis, and clearly subjects who have got an active dissection. Now, in certain specialist settings, we will exercise people who have aortic stenosis or HOCM, and the reason we do this is to try and look for a gradient under exercise. So, positive exercise tests. These features include having classical angina pectoralis, ST depression of more than 1.5 millimeters at 80 milliseconds after the J point. So remember, this J point has got to be 80 milliseconds after that. Developing an arrhythmia. This may be they develop ventricular tachycardia or atrial fibrillation, all of which can be induced by ischemia. Developing ST elevation, clearly that's a worrying sign and will be put out alarm bells that this is a positive test. Blood pressure not rising by 15 millimeters of mercury. So normally during exercise test, or when we exercise, the total peripheral resistance falls, meaning that your diastolic pressure falls, and as a result your heart works harder, increasing the systolic pressure, leading to a wider pulse pressure. If we don't see that increase in pressure, that could well be a sign that there's underlying ischemia, and would again alert the clinician that something may be subtly abnormal with the exercise test. On the right-hand side of our slide here, you see the equivocal group. And then these are subjects who we often are presented with clinically. Typically, these may include people who have less than 1 millimeter of ST segment depression, people who are unable to do a proper test, and those who present with very unusual atypical chest pains. False positive exercise tolerance tests include young females, subjects who hyperventilate, subjects with syndrome X, subjects who are anemic, so if they have a very low hemoglobin, even in the presence of normal unobstructed coronary arteries, they can often have a positive exercise test, and those with left or right ventricular outflow tract obstruction. Contraindication to thrombolysis will include surgery or major trauma, having a head injury less than 2 weeks preceding the episode requiring thrombolysis, active bleeding less than 10 days before, intracranial tumour or previous subarachnoid hemorrhage, recent stroke of less than a year, blood pressure of more than 210 over 100 millimeters of mercury, bleeding abnormalities, being pregnant whereby they have a huge vascularization of the placenta, and administering thrombolysis is clearly a very bad thing and can cause major hemorrhage. And then conditions such as dissection or pericarditis, or a non-ST elevation infarct. Relative contraindications which requires clinical judgment include those with hemorrhagic diabetic retinopathy and hemorrhagic stroke. Now clearly this list is a list which we apply to patients having thrombolysis, and I suspect in coming years we'll be referring to lists such as this much less as we provide primary PCI to more and more people. We'll now look at the mainstream modalities for investigating chest pain. These include exercise testing, which we've spoken about, dobutamine stress echocardiography, thallium, CT calcium scoring, CT angiography, and coronary angiography. Now clearly, as we work down this list, tests become more invasive and also require the administrations of various chemicals or nuclear radiotides, or indeed a dose of radiation to image the patient properly. By far and away, the most frequent test performed on this list currently is an exercise tolerance test, as we've spoken about. But NICE guidelines are currently working their way through, which will mean that the first line investigations is likely to become CT calcium scoring in the not too distant future. Here we see an illustration of a coronary angiogram on the left side of your screen, and you can see there's a white arrow which clearly illustrates a narrowing in the circumflex artery. On the right-hand side of the screen, you can see two different non-invasive imaging modalities. On the top right is an echo-based image where we have contrast perfusing through the myocardium, and you can see where the white arrows point a blackened area or grey-black area where the contrast is not perfusing properly, and this is the region of the narrowing in the circumflex artery. And then in the same patient, they've also undergone thallium investigation, and you can again see the nice yellow colouring throughout most of the ventricle, and there's an area which is pointed out by the white arrows which appears not to be being perfused by the thallium. So these non-invasive tests would be done, of course, first and point to the fact that there's a problem with one of the arteries which needs attention at angioplasty. Spoken briefly about CT calcium scoring, and the NICE guidelines is going to push this into the mainstream agenda for us. Above and beyond that, it's possible to do CT coronary angiography. This is where we use a small bolus of contrast into a peripheral vein and take a very rapid sequence of images of the contracting heart to image the coronary arteries. On this slide here, you can see that this subject has a severe left anterior descending stenosis distally, and you can see I've labelled all the other arteries. We'll now move on to question 3. 30-year-old man presents with 3 hours of central crushing chest pain. He admits to regular cocaine use, including the evening that he presented to the emergency department. He once again has a whole host of risk factors and is hypertensive. Which of the following is the most appropriate way to manage this gentleman? If you went for percutaneous coronary intervention, you were correct. This gentleman has clear evidence of ST elevation, which is suggestive of a myocardial infarction. Given he also has symptoms, we need to treat this as though it's an acute myocardial infarction, and we need to have a look at these arteries in the catheter lab. Cocaine is clearly very, very bad for arteries in a number of ways. It causes spasm to coronary arteries, which independently of the development of atheroma can cause chest pain, ST elevation or ST depression. And it causes, and through mechanisms of increasing blood pressure, it can lead to the premature development of atheroma, which can of course then lead on to the development of a coronary artery disease and thrombus formation and presentation, as in this question, with an acute myocardial infarction. We would treat this patient coming into A&E in exactly the same way as we would treat another patient, but perhaps have some caution with administering some of the drugs which we know are an essential part of the treatment algorithm, the long-term maintenance of someone with established coronary artery disease. And particularly I would like you to pay attention to administration of beta blockers, as in this group, beta blockers can worsen coronary spasm and can make symptoms worse. This is a question which frequently comes up in the college examinations. So just to summarise, the treatment options of acute myocardial infarction include percutaneous primary coronary intervention, which we've spoken about, thrombolysis, coronary artery bypass grafting, and this may well be an option if a patient comes in, they have imaging of their coronary arteries, and they have such severe disease that we're unable to offer an angioplasty, or it may be that during angioplasty technical difficulties arise which mean that the patient then needs to go on to have an emergency bypass operation. This happens rarely, but it is an important treatment mentality not to forget. And then the bottom group is a conservative management. And these may be old people who come in with only a very small artery affected, of which performing angioplasty is futile because the stents are likely to occlude, or in someone who's extremely high risk or otherwise very compromised and unable to undergo a procedure or thrombolysis. The group is very similar for those who present with an acute coronary syndrome. So these are typically people with non-ST elevation myocardial infarctions with positive troponins and good coronary symptoms. And the treatment here would include percutaneous coronary intervention, so looking at their arteries, imaging them and opening up vessels where appropriate. Again, coronary artery bypass grafting for severe disease in 3 vessels, usually in subjects who often have diabetes, where the vessels are very small and not very amenable to angioplasty. And of course, we have medical therapy, so this may well be subjects who repeatedly come in with very difficult to treat disease, or in subjects who are very, very elderly or not amenable to either bypass surgery or coronary intervention. So question 4. 67-year-old man is referred to the cardiology clinic with angina and episodes of syncope, has a history of hypertension managed with ramipril and indapamide, and suffered an inferior myocardial infarction some 4 years ago. On examination, his blood pressure is 125/105. 105. He has a soft ejection systolic murmur, loudest at the apex. He has some evidence of heart failure, and you're asked which of the following is likely to be the most significant problem driving his symptoms. If you answered C, aortic stenosis, you're right. Clearly, this gentleman presents with symptoms which may all be suggestive of either ischemia, which could be reduced by an arrhythmia, by coronary artery disease, or indeed a valvular abnormality such as aortic stenosis. What would alert me particularly to this being aortic stenosis is clearly his murmur, so he has a systolic murmur, and the fact that he has both angina and episodes of syncope. And I'd want to rule this out prior to any other investigations. Clearly, if this is aortic stenosis, it's likely to be causing him some difficulty, because he looks like he's now going on to develop signs of decompensation. So with any valvular abnormality, or indeed with any arrhythmia, one of the main reasons that subjects get angina-type symptoms in the presence of normal coronary arteries is the normal homeostatic regulation of coronary blood flow becomes disrupted. Coronary arteries, unlike normal systemic arteries, get most of their blood flow during diastole and not during systole. So circumstances which arise to alter this delicate balance can leave people with an inadequate supply to their myocardium and result in angina or dyspnea. Typical scenarios may include mitral stenosis, whereby there's less left ventricular filling, and often accompanied by a high ventricular rate, which means that the diastolic time period is shortened. So this is why often in mitral stenosis we'll administer beta blockers to slow down the rate, allow more time for filling, and prolongate the diastolic period, allowing better coronary perfusion. And indeed in this scenario here with aortic stenosis, where the perfusion pressures, which are normally delicately balanced between that in the myocardium and that in the aorta, become disrupted. In aortic stenosis, the left ventricular pressures are very, very high, and the aortic pressures can become very, very low. So the normal driving gradient down the coronary artery becomes lost, and this can lead people, even in the presence of unobstructed coronary arteries, to develop symptoms of chest pain and dyspnea. We'll now do the next question, question 5. A 50-year-old man with long-standing hypertension presents acutely with severe central pain radiating through to his back. He looks unwell with a resting tachycardia of 110 and a blood pressure of 150/96. There are no murmurs, a neurological examination is normal. An urgent CT scan of his chest confirms a type A dissection. The local cardiothoracic centre is contacted and urgent transfer arranged. He's received appropriate analgesia, but how do you manage his blood pressure? If you answered B, labetalol, you're right. One of the most important things you can do in the treatment of acute dissection is to ensure that blood pressure is well controlled. Ideally, you want an agent with a short half-life which works quickly and its effect can be regulated dynamically, and also one which reduces the cardiac contractility. Clearly on the list here, labetalol is your first-line drug. Although it's not the only drug which we can use, and indeed in some circumstances you may use nitroprusside. I would avoid using agents such as amlodipine or enalapril orally, as their effect will be very long-lasting and may be disadvantageous if the patient's blood pressure was to fall precipitously, and of course they will take some time to become effective in the patient, maybe taking an hour or two before they start to lower blood pressure. There are two broad classifications of dissections which you should know about: DeBakey and Stanford. The DeBakey classification is divided into type 1, type 2 and type 3, as you can see illustrated here. A DeBakey type 1 on the left-hand side of your diagram involves an area extending from the aortic root all the way down to the iliac arteries. A type 2 in the middle just involves the aortic root. Stanford lumps these two together as a type A. As a rule of thumb, anything involving the aortic root carries with it a much higher mortality and a worse prognosis, and this is the group who we want to act on usually very quickly and often need operative intervention. In contrast, a DeBakey type 3 or a Stanford type B usually involves other parts of the aorta, not the aortic root. This is frequently managed more conservatively, often with blood pressure lowering and then semi-elective surgery in the next day or the day after that. Depending on the precise nature of a dissection, can present with different symptoms. So dissection forwards can present with rupture, neurological abnormalities, or loss of pulses, whereas a dissection which ruptures backwards can present with valvular abnormalities such as aortic regurgitation, tamponade, or myocardial infarction. Dissection is frequently precipitated by elevated blood pressure, which of course, as we've spoken about earlier, could be itself elevated as a result of administration of drugs such as cocaine. Congenital abnormalities such as coarctation will clearly elevate blood pressure and again predispose to it, as can conditions such as connective tissue conditions such as Marfan's or Ehlers-Danlos syndrome. We must also consider the increased risk of dissection in pregnancy and of course the effects of trauma. Final question is question 6. In which of the following scenario have statins not been shown to be a benefit? If you answered C, you'd be correct. We spoke about earlier in the lecture about the importance of cholesterol and elevation of cholesterol as a risk factor for coronary artery disease and stroke. Most of the research which has been carried out is in secondary prevention, usually after myocardial infarction. And there's good evidence there that administration of statins is highly effective at reducing the proliferation of further coronary artery disease and preventing further myocardial infarctions. There's much less evidence, however, for the administration of statins as a primary prevention drug. Trials underway at the moment looking at this in much greater detail, and there may be a case in the future whereby we treat people with mildly elevated cholesterols if we can confer a good enough benefit for reduction of myocardial infarction and coronary artery disease. So just to summarise, the secondary prevention of coronary artery disease would be having good blood pressure control, so less than 130 millimetres of mercury in a non-diabetic subject and 120 millimetres of mercury as our target in a diabetic subject, having a cholesterol of less than 4, having very good sugar control, smoking cessation and weight loss. We've spoken about some of the important factors in precipitating chest pain, but there are certain other factors which we must bear in mind which can exacerbate symptoms. These include arrhythmias, whether they be slow or fast rhythms, so tachy or bradyarrhythmias, patient who's profoundly anemic with a low hemoglobin, subjects with intercurrent disease, so patients who may well have minor coronary artery disease who become very septic and become very hypotensive. Patients who are hypoxic, maybe at altitude with mild coronary artery disease, may well develop symptoms. And clearly those who have had trauma, both to the thoracic cavity and a contusion to the coronary arteries or the myocardium itself. That concludes the first of these past test cardiology videos. I hope you can join me for the second lecture where we're going to be looking at cardiac electrics and also some physiology.